Aloha. I'm going to get started. Welcome. I am Dr. Steve Orenstein. I'm a clinical psychologist, and I'm chief of staff at the Pono Eating Disorders program. So we're going to talk today about eating disorders. To begin, I would like to invite you all to grab what's left of the chocolate, because we judge the outcome of our talks by how much junk we speak. I think it's up a little too high. Is that better? Yeah. Okay. There's a moment of Jimi Hendrix for you, but those of you who know who Jimi Hendrix was. I'm dating myself a little bit. Anyway, so we have been treating eating disorders for 30 years, actually for 35 years here in Hawaii. And I want to talk to you a bit about the history of eating disorders treatment in Hawaii. But to begin, of course, I want to talk to you about what eating disorders are. Anorexia, bulimia, and binge eating disorder comprise a nationwide epidemic. According to the National Institutes of Health, there are as many as 10 million people in this country at any one point in time who are in need of treatment for an eating disorder. 90% of that population is women, 10% of that population is males. Anorexia nervosa is the only lethal behavioral health disorder. There's a 10% fatality rate in anorexia nervosa, and it's the leading cause of death in women between the ages of 18 and 29. Even patients who fully recover from their eating disorders, and we believe that full and complete recovery is entirely possible, but even those who do recover completely might be subject to subsequent medical conditions, including type 2 diabetes, fibromyalgia, heart disease, osteopenia and osteoporosis, problems with pregnancy and childbirth, and dental disease. I want to say just one little other word about dental disease. Some of you may not know this. Dentists might be amongst the primary people involved in eating disorders treatment. Now, they don't tend to be, but it'd be nice if they were, because bulimic patients destroy the enamel on their teeth with their self-induced vomiting. And the kind of enamel wear that happens in bulimia only happens because of bulimia. So dentists do see this. They see this all the time. If any of you are dentists, know dentists, go to the dentist. Help them become more aware of this. It's a significant problem. Anyway, back to, what are these problems? Yes? Slideshow mode. Let's see. Slideshow mode. Does that make it better? Okay. Thank you. Who needs an IT person when they've got you? Actually, the IT person didn't help with that. Okay. So anorexia nervosa, which is probably the most commonly thought of eating disorder, is characterized most by self-starvation, a pathological fear of becoming fat, which is typically accompanied by significant, even severe weight loss, social withdrawal, and it might involve purging behavior as well as self-starvation. Bulimia, less commonly called bulimia nervosa, is characterized by recurrent episodes of binge eating, followed by compensatory behavior such as self-induced vomiting, laxative or diuretic abuse, fasting, excessive exercise. I want to emphasize that last one because a lot of people don't realize that there are many people who suffer eating disorders who are bulimic, in fact, and don't purge in the conventional way of using self-induced vomiting. They exercise excessively. In our culture, of course, we value fitness and exercise is seen as a really, really good thing. but I just want to put this out that exercise can also become compulsive and can become part of an eating disorder. Finally, the most common of all the eating disorders, and yet probably one of the least understood, least diagnosed, least recognized, is binge eating disorder, which is characterized by recurrent episodes of out-of-control binge eating, typically followed by physical distress and overwhelming feelings of shame and disgust. Many people who struggle with what we call yo-yo dieting, who have been involved with dieting over and over again over many, many years, actually suffer with eating disorders. And these problems, unfortunately, sadly, often go completely unrecognized, undiagnosed, untreated. All eating disorders are associated with severe disorders of mood, loss of self-esteem, and deterioration of social or occupational functioning, and may also be associated with suicidality, family dysfunction, loss of ability to concentrate, rapid weight gain or loss, and other comorbidities. They may also be associated with a variety of medical complications, including musculoskeletal abnormalities, electrolyte imbalances, gastrointestinal distress, dental decay, pulmonary or cardiovascular or endocrinological problems, genitourinary problems, hair loss, dermatologic problems, etc., etc., etc. Pretty much anything that might go wrong with your body is more likely to happen if you have an eating disorder. Now, when we look at the Dsm-5 criteria for these problems, we get into a little bit more detail. With anorexia nervosa, again, we're not just thinking about somebody that's really thin. Many people are naturally thin. It would be wrong for any clinician, for example, to assume that just because a thin woman or a thin man walks into his or her office that they're looking at somebody with an eating disorder. Eating disorders, anorexia nervosa especially, are characterized in part, in important part, by a fear of becoming fat and by a distorted body image which leads the person afflicted to see herself or himself as fat even when they're not fat. Years ago, when we ran our first eating disorders program here in Hawaii, which was an inpatient program at Kahimahala Hospital, most of you, I think, are probably too young to remember that, and it's a little scary for me to acknowledge that I was actually working all those years ago, but I was. We used to run a television ad to help promote that program, and in the ad, which was very simple, it showed a thin woman standing before a mirror and seeing an image of herself that was 4 times that size. That is part of what the anorexic person goes through, a severely distorted body image. So there is this intense fear of becoming fat or of gaining weight, persistent behavior that interferes with weight gain. Anorexic patients oftentimes just won't eat. We have treated patients at our facilities who are so nutritionally undernourished that they're at death's door, and yet they'll insist, no, I can't eat, I'm still too fat, etc., etc., etc. Bulimia is similar but not exactly the same. Sometimes anorexics do become bulimic on their path to recovery. Bulimia is characterized by recurrent episodes of binge eating, as I said. What is a binge? Binge eating is consuming in a discrete period of time, let's say within a 2-hour period, an amount of food that is definitely much larger than most people would eat during a similar period of time and under similar circumstances. Some people think that people who binge only binge on fun foods, on sweet foods, on chocolate and such. It's not true. We've known people who suffer with bulimia who binge on cauliflower. It really doesn't matter what people are eating. Binging has to do with the behavior, not with the food itself. In bulimia, these episodes of binge eating are typically accompanied immediately afterwards by some kind of purging behavior, which is typically self-induced vomiting, and as I said before, might also involve exercise. Now, binge eating disorder, which I said is probably the most common of all the eating disorders, are characterized by recurrent episodes of binge eating, which are not necessarily followed by any kind of purging behavior. But what does follow binges in the case of somebody suffering with binge eating disorder is extreme psychological distress, especially feelings of shame, disgust, guilt, depression. These binge episodes are typically done in private. Sometimes people do this only at night, sometimes they do it all day long. In case you're wondering, we have treated people who binge or binge and purge multiple times every day. So you might also imagine that when somebody is doing this, engaging in this kind of behavior in the context of being part of a family, it can also create problems in the family. Consider, if you are binging an extraordinarily large amount of food every day, 3 or 4 times a day, how much is that going to cost? We're talking potentially thousands of extra dollars a month in food costs. How might that affect a family? Common comorbidities with eating disorders, unfortunately, are plentiful. Many patients with eating disorders do suffer with borderline personality disorder. However, and this is a caution, we have found many, many times that often people look as if people who are in the throes of an eating disorder seem as if they have a borderline personality disorder. They don't. They're just nutritionally severely imbalanced. Thus, their moods are severely unstable. Once their eating behavior normalizes, they don't start showing those same indications of borderline personality disorder. Nonetheless, many eating disorders patients do suffer with borderline personality disorder. Alcoholism and other substance abuse is another common comorbidity. Sometimes people use the term drunkorexia. There are anorexic patients who, rather than eating, they drink. So you can imagine how dangerous that can be after a while. If you're not eating and you're just drinking, that's how you're getting your calories, that's how you're getting your nutrition. At the same time, losing a lot of weight, becoming more and more imbalanced, becomes really, really dangerous. Depression might seem like an obvious comorbidity. It's certainly quite common. Many anorexic, bulimic, binge eating disorder patients do suffer with depression. This may be why it was quite common for many, many years for doctors trying to treat eating disorders to treat eating disorder patients with antidepressants, as if the cause of the eating disorder was depression. Now, there may certainly be occasions when depression does wind up triggering eating disordered behavior as a person strives to cope with her or his down moods. But more often we have seen that it's the other way around. That getting stuck in the throes of an eating disorder from which you're unable to escape is depressing. Post-traumatic stress disorder is something that we've learned more and more about over the years. Many of our patients who are most seriously disturbed, sadly and unfortunately, have a history of a significant traumatic event, typically sexual in nature, not exclusively. I remember when we were in graduate school many, many years ago, not only did the graduate school never mention anything about eating disorders, but we never learned much about, childhood trauma. And certainly in recent years, we've all, I think, come to know how common childhood trauma is. Childhood trauma is often, again, very closely associated with the development of an eating disorder, especially during the early teen years. Now, the role of psychiatric medications, while I've mentioned it already, I don't want to suggest that psychiatric medications can't play an important role in the treatment of eating disorders. But I will say that psychiatric medications do not offer a cure for eating disorders. If people are depressed, people struggle with anxiety and other such symptoms, of course medications might be helpful to them. But the way we see it is that psychiatric medications ought to always be used as an adjunct to psychotherapy in the treatment of these problems. There are a number of levels of care involved in the treatment of eating disorders. Probably the first level of treatment for most cases would be individual outpatient therapy. You discover you're struggling with bulimia or anorexia or some other maybe less fully formed type of disordered eating, and you go to see a therapist. And that therapist, psychologist, psychiatrist, social worker, psychotherapist of any kind certainly might be helpful. Sometimes that's all people need. But of course, as you might imagine, to be able to make use of psychotherapy, you have to be, let's say, reasonably stable, reasonably well nutritioned. If you're starving, you're not going to be able to make much use of any kind of cognitive therapy because your cognitive part isn't going to be working so well. But cognitive behavioral and dialectical behavior therapy have been shown to be very, very, very useful in the treatment of these problems. Problem with individual outpatient therapy often is, however, that the psychotherapist is not enough. The person also needs to work with a dietitian, needs to be monitored by a medical doctor, and as some of you may already know, in the outpatient world it can be very difficult to coordinate those activities. Moreover, sometimes, again, sadly and unfortunately, psychologists and medical doctors don't communicate all that well with one another. Sometimes they don't talk with one another at all in the course of a treatment. With eating disorders, it requires that the treatment team really be a team. For many people, in any case, individual outpatient therapy, even if it's supplemented with some kind of nutritional therapy and or medical care, is not going to be enough. Their behavior is too out of control, and or they've lost too much weight, and or there's too much family stress, and or. And what they need is a higher level of care. Now, 17 years ago, Dr. Johnston and I developed what actually became the very first intensive outpatient program for the treatment of eating disorders in the world. Imagine that, right here in Honolulu, we did something that had never been done before. And the IOP that we started is still around. That's the Pono program in Honolulu. And in intensive outpatient therapy, typically patients will come in for 3 or 4 3-hour group sessions each week. And this will be supplemented by individual work with a dietitian, individual psychotherapy, and medical monitoring by his or her regular family physician, PCP. Intensive outpatient therapy has become the treatment of choice in most cases. There are now eating disorder IOPs all around the country. And most of the people that are getting treated for eating disorders in the United States are getting treated in IOP programs. One of the things that's great about IOP programs is the group support. As with AA, which some of you may be familiar with, the group support is a powerful, powerful addition to the therapy process. As with alcoholism, people who struggle with eating disorders can oftentimes really get to feeling very, very alone, very, very isolated. And having people around them to whom they can turn for support, with whom they might be able to share their struggles, can be of critical importance. Another thing that is a significant factor in making IOP a powerful and very, very useful treatment alternative is that the care that's being delivered to patients can be very well coordinated. The treatment team is right there. The dietitian, the psychologist, the therapist, the medical doctor, they're all talking to each other all the time, sharing information, revising their treatment plan as needed, etc., etc. And yet, for some patients, this is not enough either. They need an even higher level of care. Typically, that is because they're really not eating enough and or they're continuing to lose weight. And as can be easily seen, if you lose enough weight and gets to the point where you're starving, medical complications can arise very, very quickly. So for that, there is what we call a partial hospitalization program. And a partial hospitalization program is like an expanded IOP. Rather than somebody coming in 3 or 4 times a week for 3 hours, they're coming in 5, even 6 times a week for 7 or 8 hours. And they're actually eating a couple of meals each day. So the program is helping to ensure that the people are much more adequately nutritioned and given the kind of support that they need. Partial hospitalization programs can help restore weight to people who have lost too much, and can also, again, provide more intensive social support for people who have grown to be much more isolated than what is safe. But partial hospitalization programs are not okay, not adequate for people who are even more seriously disturbed and or having suicidal ideations. Suicidal ideation is unfortunately not uncommon with these problems. These are people who feel out of control, who know that they're sort of spinning and can't stop doing this destructive behavior about which they feel incredibly ashamed, which they know is really self-destructive. When they get to that level, or if they are at that level, they need a residential treatment. Now, in residential treatment, such as what we happen to offer here on Maui, the patient enters into a homey, small, comfortable environment in which their care, their staff, everything about it is completely focused on and dedicated to the treatment of their eating disorder. Residential treatment was first developed about 25 years ago in response to hospitals failing to offer adequate care for these patients. Hospitals sometimes still do play an important role, but the role that they can play in eating disorders is when a person is dying, they need to go into the hospital and get nutritionally restored to help save their lives. They need to get nutritionally restored so that their brains start to function better, so that they can actually start making use of psychoeducation and psychotherapy. Sometimes, as I've mentioned already a few times, eating disorders can take somebody's life, and it becomes our job as providers to help save their lives. In residential treatment, staff is fully dedicated to the treatment of eating disorders. And let me say a few other things about just the criteria here, because I want to turn this over to Dr. Johnston in just 2 minutes. Outpatient level of care, a person really can't be less than 85% of their normal body weight, because lower than that it becomes a little bit dangerous. And you shouldn't take the risk of treating somebody who's that unstable. You may not realize this if you haven't dealt with these kinds of problems in the past. It would be hard to imagine, but things can turn really, really quickly in the cases of anorexia. Somebody can seem fine or well enough on Thursday, and Friday they're in cardiac arrest. Partial hospitalization, we look, the weight is important because the weight gives us some sense of the overall medical stability. With partial hospitalization, we like for people not to be any less than 80% of their expected normal body weight. For residential care, they could be 75% of their normal expected body weight. If it's less than that, they need to be in the hospital. A few more words about residential care and why it can be so useful and valuable in treating eating disorders. Again, you get a fully dedicated treatment milieu and protocol. Get a fully trained and supervised clinical staff with a cohesive treatment philosophy dedicated to one thing: treating the person's eating disorder. Eating disorders are a specialty. Many of you may treat eating disorders. I hope many of you become interested in treating disorders, because we always need good, skilled providers in this field. But this is a very demanding field, The skill set that's required is somewhat different than what's required for a lot of other kinds of therapy, because this can be a very challenging patient population. And of course, you're also looking at a patient population who could die on you if mistakes get made or they don't get the care that they need to receive. Get a multidisciplinary treatment team with expertise in eating disorders, using all kinds of treatment modalities, including EMDR to help with trauma, cognitive behavioral therapy, dialectical behavior therapy, thought field therapies to help them manage their anxieties. As I said before, a safe, comfortable, home-like setting, a 24/7 nursing staff, proximity to a hospital in case problems should arise, and an opportunity to provide family support in the right kind of environment. Typically, very, very often, I should say, somebody that's come into residential treatment has come out of a home environment which has become, if not toxic to them, intolerant of their eating behavior. Mom and dad, husband, wife can no longer monitor them well, provide them what they need in terms of support, psychologically or nutritionally. They need to get out of that environment and into a place where they'll receive the kind of support that they need. I'm not going to speak about the history of treatment in Hawaii. You can take a look at that. It gives you an idea of what we have been through over the years, what has happened in Hawaii over the years. You can see it's quite a long history, beginning in 1982 with the founding of the Anorexia and Bulimia Center of Hawaii, and evolving all the way until now, where we've got a full range of services available for patients throughout Hawaii. Okay. I am now going to turn this over to Dr. Anita Johnston. Dr. Johnston has been my partner in this work over many, many years. She's the author of Eating in the Light of the Moon, which has been one of the best-selling and best-received books on why women struggle with food. And without further ado, I'm going to turn it over to Anita.